Good morning, ladies and gentlemen. Thank you very much for having me. It's an honor to present in front of you the results of our international core study investigating risk-reducing surgery, specifically in the cohort of young women with breast cancer and BRCA pathogenic variants. Here are my disclosures. Cancer risk management strategies, including bilateral risk-reducing mastectomy and risk-reducing salpingo-oophorectomy, are widely recommended in BRCA healthy carriers. However, in BRCA carriers with prior diagnosis of breast cancer, additional challenges should be considered in the counseling, particularly for young patients. The risk of relapse of the primary breast cancer should be balanced with the risk of developing a second primary malignancy. Although these surgical procedures are known to reduce the risk of breast and/or ovarian cancer, while risk-reducing salpingo-oophorectomy has shown to improve overall survival in BRCA carriers of all ages with prior history of breast cancer, the impact of risk-reducing mastectomy in reducing mortality remains controversial. And when we counsel specifically young patients, we should keep in mind that these surgical interventions may have an important impact on reproductive plans and quality of life. And to date, no prior studies have focused specifically on the role of these risk-reducing surgeries in BRCA carriers with prior history of breast cancer at a young age, defined as 40 or less at the time of diagnosis. The BRCA-BCY collaboration is an international multi-center hospital-based retrospective cohort study that included patients with diagnosis of invasive breast cancer stage 1 to 3 that was diagnosed between January 2000 and December 2020. All the patients were young at the time of breast cancer diagnosis, so 40 years or less, and all the patients were known to carry a germline likely pathogenic or pathogenic variants in the BRCA genes. We excluded patients with stage 4 de novo breast cancer, those with history of ovarian cancer or other malignancies other than breast cancer, without prior breast cancer, those with BRCA variant of unknown significance, and BRCA healthy carriers. And for this specific analysis, we also excluded patients with no information on uptake or timing of risk-reducing surgeries or their uptake before diagnosis of breast cancer. I will not go into the statistical analysis plan, but I just wanted to use this slide to highlight the fact that we were fully aware on the complexity of this analysis, on the potential biases with this type of analysis. And so a predefined statistical analysis plan was prepared by a team of 4 experienced statisticians together with the study team. And we made several efforts that are listed in this slide to try to reduce the potential issues of bias with this type of analysis. Overall, the main goal of this analysis was to look into the association between risk-reducing surgery and survival. So in other words, to see if undergoing these risk-reducing surgeries will improve the outcomes of young women with prior diagnosis of breast cancer and BRCA carriers. From 190 centers in 33 countries and 5 continents, we included in this specific analysis 5,290 young women with breast cancer and all BRCA carriers. Among these patients, subsequently to breast cancer diagnosis, 2,910 underwent risk-reducing mastectomy and 2,782 underwent risk-reducing salpingo-oophorectomy. The overall follow-up in the overall cohort was 8.2 years. These are the patient and treatment characteristics in the whole cohort. The majority of patients were treated in high-income country, 86.7%. Median age at diagnosis of breast cancer was 35 years. Half of the patients were tested for BRCA before diagnosis of breast cancer or within 6 months after diagnosis of breast cancer. 2/3 of the patients, 63.5%, were BRCA1 carriers. Half of them had non-negative disease. In terms of breast cancer subtypes, 35.9% had hormone receptor positive HER2 negative disease, and 49% had triple negative breast cancer. Most of the patients, more than 90%, received chemotherapy in the adjuvant or neoadjuvant setting. Starting with the first analysis on risk-reducing mastectomy, 2,910 patients, so 55% of the total cohort, underwent the surgical procedure at the age of 36.6 years, and the surgical procedure was performed after a median time from diagnosis of 0.8 years, meaning that the median time was less than 1 year after breast cancer diagnosis. And the median follow-up after risk-reducing mastectomy was 5.1 years. Looking at the overall survival, risk-reducing mastectomy was associated with a significant improvement in overall survival with an adjusted hazard ratio of 0.65, meaning a 35% reduced risk of dying for those patients that underwent risk-reducing mastectomy. The three models that we use to try to reduce the potential burden of biases with this type of analysis provided consistent results, so very similar adjusted hazard ratios. Risk-reducing mastectomy was also associated with a significant improvement in both disease-free survival and breast cancer-free interval, with an adjusted hazard ratio of 0.58 and 0.55 respectively, so more than 40% reduced risk of developing a recurrence or a breast cancer event during the follow-up. And as expected, patients that underwent risk-reducing mastectomy had a significantly lower risk of developing a second primary breast cancer. Moving now to risk-reducing salpingo-oophorectomy, 2,782 patients, so 52.6% of the total population, underwent this surgical procedure at a median age of 39.7 years, and the median time from diagnosis to this surgical procedure was 3 years. In terms of overall survival, risk-reducing salpingo-oophorectomy was associated with a significant improvement in overall survival with an adjusted hazard ratio of 0.58, meaning a 42% risk of dying for those women that underwent risk-reducing salpingo-oophorectomy. And again, the three models in the sensitivity analysis provided consistent results. Risk-reducing salpingo-oophorectomy was also associated with a significant improvement in both disease-free survival and breast cancer-free interval, with an adjusted hazard ratio of 0.68 and 0.65 respectively, so more than 30% reduced risk of developing a recurrence and a breast cancer event for those women that underwent risk-reducing salpingo-oophorectomy. So in conclusion, this global study, including 5,290 young BRCA carriers from 190 centers worldwide, provides evidence on the association between risk-reducing surgeries and survival outcomes among young BRCA carriers with a prior history of breast cancer. Our results show that undergoing this surgical procedure was associated with improved overall survival, disease-free survival, and breast cancer-free interval. But I want to highlight again in this special clinical setting, so women diagnosed with the first breast cancer below the age of 40 years and carry a germline BRCA pathogenic variant. So our final conclusion is that we hope these findings may help to improve the counseling on cancer risk management strategies for BRCA carriers with young onset breast cancer, so below the age of 40 years. And this data should not be used to counsel healthy BRCA carriers or BRCA carriers with diagnosis of breast cancer at an older age. And here in these slides, all the people and entities that I really wish to thank for allowing us to make this academic effort. And again, thank you very much for your interest in our study and for being here today.
Wonderful, thank you. I did have a question for you that the data is in the abstract, but I don't think it was highlighted on this set of slides, specifically for these women undergoing oophorectomy. Mm-hmm. There was a quite stunning decrease in, I believe it was overall survival in the triple negative group, around 80 or 85%. I was wondering if you could comment on that, because we really counsel some of our patients in clinic that they could potentially delay having an oophorectomy, particularly in the setting of triple negative breast cancer, where we don't think we're getting the benefit of ovarian suppression out of the oophorectomy. So I was wondering if you could comment on that.
Yeah, thank you very much for the question. Indeed, for the sake of time, I didn't include the subgroup analysis, but indeed this is a very important one. For the risk-reducing mastectomy analysis, there was no interaction, so the benefit was observed in all the patient subgroups. However, it's true that for risk-reducing salpingo-oophorectomy, there was an interaction according to subtype as well as specific BRCA gene, mutated gene. And specifically, the benefit of risk-reducing salpingo-oophorectomy was greater for patients with BRCA1 pathogenic variants and for those with triple-negative disease as compared to those with BRCA2 pathogenic variants or luminal-like disease. So the explanation is probably related to the specific BRCA gene, because the risk of ovarian cancer in BRCA2 carriers is lower as compared to BRCA1 carriers, and the patient population included in our study is very young, and the risk of ovarian cancer in BRCA2 carrier is higher at an older age, and also the follow-up is relatively short, even though it's 8 years, it's still relatively short to see ovarian cancer. So going back to the question on triple negative luminal-like, to me this is probably most explained by the different distribution of breast cancer subtypes in BRCA1 carrier and BRCA2 carrier, because BRCA1 carrier mostly develop triple negative breast cancer, a few of them develop hormone receptor positive disease, and it's the opposite for those with BRCA2 pathogenic variants. And so to me it's probably the explanation of the benefit in BRCA1 carriers more than in BRCA2 carriers that will explain also the triple negative versus hormone receptor positive analysis.
Wonderful. Thank you. And we'll open it up to questions from the audience or online.
Megan Brooks from Medscape. Dr. Lathrop, could you give us your opinion on how you might use these findings in clinic?
Yeah, so I think this is, as was pointed out at the beginning, we have data on patients who are carriers for upfront reduction risk surgeries, but this is specifically in young patients that have already been diagnosed with breast cancer, which was an area that we didn't have this level of data in. So I think when you're sitting in clinic with patients and they, ask, well, I inherently understand how I might have to have surgery on my breasts, but why do I need my ovaries removed? Or when do I need my ovaries removed? Or can I wait? Is it safe? What's my risk if I decide, because these are women who are still potentially in their reproductive part of their life. And, oftentimes we'll get the risk of, well, I want to have more children, but I also don't want to put myself at risk. I already have 2 children. How do I balance those two things? And having data sets like this really help us say, okay, well, this is potentially, our best estimate of the amount of reduction of risk you could have by having the surgery now. So it's very valuable to be able to give patients that information.
And maybe if I can just
Absolutely.
a little piece, I really wanted to stress one more time that these are patients with first diagnosis of invasive breast cancer below the age of 40 years. So it's not all BRCA carriers. So I don't want that this message that these surgeries are so important will go to all BRCA carriers. These apply to women that have already been diagnosed with breast cancer below the age of 40, and even those not carrying a BRCA mutation that have a diagnosis of breast cancer below the age of 40 have a very high risk of developing a second breast cancer, for example. So this is a special patient population. In this setting, we see a benefit which is probably even larger than what has been shown in prior studies.
Hi, Jamie DiPolo from breastcancer.org. I want to make sure I understand, did any of the people in the study have both risk-reducing surgeries, and how do we talk to people about that?
Yeah, thanks a lot. This also is a slide that I removed because of the sake of time. 1,804 patients underwent both risk-reducing mastectomy and risk-reducing salpingo-forectomy. So we have looked into the beneficial effect of the surgical procedure, if this was independent or was influenced by receiving one or the other surgery. The main message is that for the overall survival analysis, there's no difference, so it doesn't matter if it was only one or the other. The benefit was irrespectively of receiving both surgery or just one or the other. For the disease-free survival and breast cancer-free interval, the benefit of risk-reducing salpingo-forectomy was higher in those patients that also received risk-reducing mastectomy. And the main reason is that a patient that did not undergo risk-reducing mastectomy has a risk of developing breast cancer and the second primary breast cancer. And this is an event for the disease-free survival and breast cancer-free interval definition. And so that's why that we see that. Yeah.
And there was no difference by mutation, either BRCA1 or BRCA2?
That we did not go into those details,
okay,
because it was like a subgroup analysis of a subgroup, of a subgroup. So, thanks.
Great. Wonderful. Thank you very much.